Hey everybody, today we're going to talk about the concept of oxygenation and specifically focusing on asthma and pharmacology. Objectives of this session, we're going to compare and contrast some of the meds that are used for asthma. We're going to talk about the nurse's role. We are going to definitely focus on the prototype drugs that are listed in the chapter. We are going to talk about patient education and nursing process more in the second segment of oxygenation when we talk about COPD. All right, asthma. It's a chronic pulmonary disease with inflammatory and bronchospasm components. So it's characterized by intense breathlessness, coughing, or possibly gasping for air. And this is due to those bronchospasms, maybe that constriction, in addition to some inflammation. So when we're looking at the constriction and the inflammation, what you need to know is that histamine and other mediators are stimulated during the inflammatory response. This is going to cause an increase in mucus and edema. Bronchoconstriction and inflammation can cause the airway to become obstructed. So just to kind of give you a visual, if you've ever watched those farm commercials, especially with some of these medications, you can see that constrictions, the vessel, things are going to close up a little bit more. And then you add inflammation on top of that. So that's going to decrease the ability for air to move. There could be acute or chronic symptoms with asthma. When you're thinking of that, always think short term and long term. And symptoms, spaces between symptoms or episodes could last days to months. Asthma can also be triggered by a couple of different things: air pollutants, maybe allergies, chemicals, food, having a respiratory infection, stress, and even exercise. You always want to be mindful for a condition called status asthmaticus, and this is a very emergent situation that can result in respiratory failure. Drug therapy is going to focus on either constriction and or inflammation. Ultimately, what you want to do is you want to stop the bronchospasms or constrictions, decrease the inflammation, which is going to reduce what's happening during an attack, or hopefully reduce the amount of attacks. There's two different kinds of subclasses, so to speak. So you have quick relief medications. These are going to be either short or intermediate beta adrenergic agonists, and we're going to talk about those in depth. It could be anticholinergics or corticosteroids. Long term could be also corticosteroids, mast cell stabilizers, leukotriene modifiers, long acting beta 2s, and maybe a few more. So not to get too deep into it because we're going to start drilling down to the prototype meds that speak to these. Specific classes, we're looking at bronchodilators or anti-inflammatory. Remember, we want to stop the constriction, decrease the inflammation. We're going to focus on the starred ones, your beta adrenergic agonists. Now, these can be short-term and long-term, commonly called SABAs and LABAs. And we are going to talk about anticholinergics. For the inflammatory side of things, definitely going to drill down to corticosteroid use as well as leukotriene modifiers. When we're looking at beta agonists, these are the first line drug treatment. Now they can either be beta 1s or beta 2s. So you're going to get a little bit more of this in perfusion, but just think about this. Beta 1, because I only have one heart, going to kind of work on the heart side of the house. Beta 2, because I have two lungs. These tend to work more with the lungs. Now, not to confuse or muddy the waters, but they can also be a combo. Drugs can be combos of 1 and 2. Now, these are called non-selective. You would prefer a selective beta 2 agonist because this is going to have less side effects. Again, they can be short acting, working in a couple of minutes, and this is commonly called a rescue drug or a rescue inhaler. Long acting can take up to about 12 hours or work for up to 12 hours, and you need to know that the LABAs, or the long acting, do not stop acute bronchospasms or an attack in progress. So you want to use the short acting for those. You're going to hear me say that over and over again. When we're looking at anticholinergics used for pulmonary disease, they can commonly be combined with a SABA or a LABA, and they have an effect that's going to help with prolonged bronchodilation, because ultimately that's what we want to do. We want to dilate. When we're looking at corticosteroids, inhaled corticosteroid is used for long-term prevention of attacks, and this is again going to reduce the inflammation and edema, ultimately going to reduce the airway obstruction. Inhalation route is preferred to prevent asthma attacks. You can also give corticosteroids systemically, sorry about that, but again, not used to terminate an attack. You're always going to use the short actings for immediate treatment. If clients are on oral corticosteroids, they're used for a short duration, about 5 to 7 days. They can have some effects, and we're going to talk a little bit more about that if they're taken for a long term. And then always steroids should be tapered. When we are looking at the leukotriene modifiers, there's these inflammatory mediators, these things, they come into play, jumping on board. What these do is they work on mast cells, neutrophils, basophils, and eosinophils, and they're ultimately wanting to do is reduce the edema and inflammation and the bronchoconstriction that's happening. These can be used when persistent asthma cannot be controlled with corticosteroids or SAPAs. All right, so let's dive into some prototype drugs. We got about 4 of them that we're going to cover here. And please know that your COPD patients are also may use these as well. So we'll get a grasp on them here so then we can focus on the nursing aspect in our next presentation. Albuterol. This is a short acting, one of the SABAs, okay? It's going to be used for those bronchospasms. This is what you want to give if they're having an attack and you need to stop it immediately. It's the preferred drug. It will also help with inflammation. Sometimes you can even use it as a preventative measure for exercise-induced asthma attacks. It also comes in oral form, but those will not terminate or stop an attack in progress. So you commonly see an inhaler. When we're looking at considerations, your patient has to know how to use their inhaler. So that's going to be a huge teaching point that we're going to talk about later. Adverse effects. You can have palpitations, headaches, tremors, nervousness, and tachycardia. Now, this is related to the activation of the sympathetic nervous system. Remember, that's that fight or flight response in the body. Some less common things clients may experience: insomnia, chest pain, paradoxical bronchospasms. This is when, if they're already having trouble breathing, already having wheezing, it can get worse. You want to make sure that you do not use this medication if they are allergic or have a hypersensitivity to it. And you also want to be cautious with clients that have cardiac disease or hypertension. Remember, when we're looking at beta adrenergic drugs, you always want to think everything's connected to the heart. You have the heart and you have the lungs. The lungs are connected to the heart. So you just want to be mindful with that. For interactions, we want to be careful be mindful about the beta adrenergic blockers. These are perfusion meds, hypertension. These medications we're going to talk a little bit more in depth when we get to perfusion. So I just want you to be aware. You want to be cautious with those. And I think I talked about this in a different presentation. Be cautious with MAOIs. Lab-wise, one of the things you need to be aware with albuterol is that it can cause a decrease in a client's potassium. So always make sure you take a look at that potassium level, understand what manifestations of not hypoglycemia, hypokalemia are, and what you would need to do to treat that and what could happen with the patient. Got to be careful with this medication. You don't want the clients to have any caffeine. This is going to potentiate adverse effects. Remember, when we were talking about adverse effects, we were talking about things like tremors, palpitations, tachycardia, that sympathetic nervous system. Well, you throw some caffeine on top of it and it's going to make it worse. For overdose, overdoses of albuterol can exaggerate the sympathetic nervous system and those manifestations we just stated. So we may need to administer a cardioselective beta-adrenergic agonist or beta-adrenergic blocker, and we will again talk more about those BABs later in perfusion. All right, just a placeholder slide here. We're going to focus down on the nursing process when we get to COPD. So again, when we're talking about respiratory oxygenation, thinking about asthma and COPD together, a lot of our teaching and education is going to be very similar, so we'll talk about that in our next presentation. All right, so our second prototype drug is going to be Atrovent. I can't say the big word before that, so we're going to keep it with the ones I know how to say. Again, on exams, I'll give you both names so you can kind of get familiar with those. Uses, this can be delivered by inhalation or nasal, but nasal's for rhinitis. So for our asthma, we're going to give it inhalation route. It can be combined with the albuterol, and that combo is a first line for COPD. Off-label use can be for asthma related, may also be combined with corticosteroids. Considerations with administration, patient needs to know how to use a metered dose inhaler. So you want to make sure you brush up on that when you're thinking about what is a metered dose inhaler, how do you use it, and how am I going to teach my patient to use it? And as always, we're going to get there in teaching. You want a return demonstration on that. You want to make sure that you wait at least 2 to 3 minutes between doses with this medication. And if this medication comes in contact with the eyes, it may cause blurry vision. Adverse effects, there's very few systemic effects, but it may cause cough, hoarseness, or dry nasal passages. Clients may also tell you that they have a bitter taste when they take this medication. So one of the things you could tell them to do is after you take it, if that happens, go ahead and rinse out your mouth. This medication is contraindicated for clients that have allergies to soybeans or nuts. Okay, so you want to be very careful about that. That's one thing you're going to need to know and teach your patients, and you have to ask about that. Drug-drug interactions, be mindful if it's being used with a medication called atropine and some anti-diabetic agents, but we don't have to get too specific for that. So you just need to be mindful that those are two common ones that interact. According to the text, labs, herbal food unknown, and overdose does not occur with this particular medication. So I want you to pause for just a minute, and I want you to ask yourself why. How come that's not going to happen? Why don't we have an overdose with this particular type of medication? All right, so inflammation, part of the things, this is a corticosteroid, beclomethasone. Other steroids, prednisone is very common too, but this is one we're going to focus on here. So we need to really talk about steroid use with our clients. This particular one is the preferred drug for long-term asthma treatment. This medication, again, is going to reduce the inflammation, which is subsequently going to reduce the asthma attacks. Again, does not stop an attack. When you're administering this, again, I'm going to reinforce this. We got to teach our patients and let them know this is not the med that you're going to pick up and use if you need immediate treatment. There's few systemic adverse effects, but you do want to watch for corticosteroid toxicity. This medication may also cause cataracts and growth delay in children. Be advised that this can mask the signs and symptoms of infection, and you do not want to give this medication if a client has an active infection. So I want you to pause right here, and I really want you to find out why that is. What is it with corticosteroids that is causing the mask of infection symptoms, and why don't we want to give it if a client has an active infection? This medication taken orally can also called thrush, so you want to make sure that we teach our patients that they rinse out their mouth after every use. For contraindications, again, we're going back to the growth delay in children. So if you're working in that area administering to our pediatric population, be mindful that this could cause growth delay. There's unknown interactions, labs. Book says unknown. I do want to kind of bring it in to something's general with steroids in a general nature, that a lot of times those can cause an increase in blood glucose levels, especially when a client's on prednisone. So not to confuse the meds, there's steroids or steroids in a sense. So I would say be mindful of blood glucose levels, because if I don't normally have high glucose, then maybe I will when I'm on a medication of a steroid type. And unknown interactions with herbals or food, and no overdose on this medication. Singulair, see this a lot in the commercials. You're going to see it a lot with your patients in practice. This is a leukotriene modifier. This is used for prophylaxis of chronic asthma and exercise-induced bronchospasms. This is going to decrease the inflammation and again is not going to stop an acute tach. This can come in a chewable tablet or granules that you mix with food. Again, don't use this one for an attack, and you want to be mindful to teach your patients to take 2 hours before they exercise so that it will prevent an exercise-induced asthma attack. There's very few side effects, headache being the most common, nausea and vomiting. Rarely, but we need to know about these rare ones, because if a client starts on this for the first time, they need to know that some clients could experience suicidal ideations, hallucinations, aggression, or depression. Very few interactions. When we're looking at labs with this medication, it may increase what's called ALT. This is part of a liver function test. May not have gotten there that far with it, but I would like you to do a little research about what diagnostics labs come with liver function and start wrapping your brain around a normal ALT. No herbal or not known for herbal or food contraindications, and no overdose considerations. All right, so we made it to the end. Yay, that was quicker than I thought it was going to be. So I know there was 4 prototypes that we talked about in there. So take some time, really dive into those prototype meds. And if you have any questions at all, please post them in the Prep for Exam 1 discussion forum located in your Blackboard course.